Hello everyone, good afternoon and welcome for this session on image based discussion of dermatology questions. So what is this session all about? So per se I always tell you that whenever we are studying dermatology or its questions, lot of it is image based. So per se whenever we discuss dermatology we always do an image based discussion. So this session would be similar here, just that I've not put in questions, I've put in various images which are asked in dermatology and we can discuss the related questions related to it. Now the idea is to familiarize you with most of the images that are asked in the questions. So I'll be a little quick. If you want me to stop somewhere, you can tell me. If there is any topic which is a little unclear, we can go into the details of it. So as you were mentioning that let's start rapid fire till the session is starting, why not we do rapid fire during the session? It would be a quick revision for you and it would be fun for me. And in case you feel somewhere that we need to dwell into more details, we'll do that. Right? So are you able to hear me and can you see me and can you see my slides? Just give me some thumbs up and heads up and so we start. So perfect. So basics of dermatology. We all know the structure of skin. This is asked, what are the layers of skin from top to bottom? So sometimes they will give you an image of the skin structure or epidermis structure and give a arrow and ask you what layer this is. So you should know the layers from top to bottom: stratum corneum, lucidum, granulosum, spinosum and basal. Now my question to you is, which layer is present only in hands and feet? Which layer is present only in hands and feet? Absolutely, you all know the mnemonic, so I'm not even giving you the mnemonic. Yes, good, perfect. So this is written, but I want to know which layer is absent in palms, which layer is present in palms and soles and absent in rest of the body. It is stratum lucidum. Very good. Why is it called lucidum? What granules does it contain that it's called lucidum or clear cell layer? So stratum lucidum is one which is present in palms and soles, and it is also called as the clear cell layer because of the presence of some granules which are called as, come on quickly, eludine करके कुछ था. So they are called as refractile granules of elidine. Next question, in which layer of epidermis do you see the desmosomes? In which layer of epidermis do you microscopically see the desmosomes most? Good. You're right, Dr. Deepak, it's in stratum spinosum that you see the desmosomes. Now remember, desmosomes are present in all skin layers, but they are more evident in spinosum because spinosum is my thickest layer, and so you can see these projections which are nothing but desmosomes. Now what okay, so what is the importance of stratum corneum? How is the stratum corneum different from rest of the layers? Good, good, good. Spinosum, we are done. Very nice. Why is stratum corneum different from rest of the layers? What are the differences between the cells which you see in stratum corneum and rest of the? Yes, so stratum corneum is a dead cell layer. So you would not see any nucleus, you would not see any mitosis here. You would see flattened cells, the cells would be dehydrated. So my epidermis is formed from stratum basal and then it goes up. So by the time it reaches stratum corneum, the cells are dead, and that is why it acts as a barrier. There is no nucleus, there is no mitosis, the cells are flattened and they are dehydrated, and that is that is why it acts as a barrier function. Because it has no nucleus, it does not get affected by outside agents, it acts as a good skin barrier. So perfect. So you know all about it. Yes, I'm coming to the cells in the epidermis. So there are 4 cells that you should be knowing about. Now, one is keratinocyte, which you all know is present in all cell layers. Where is melanocyte present? Where is melanocyte present? Somebody already told me that melanocyte is present in stratum basale, and this is the cell which is responsible for pigment formation, right? Now, what is epidermal melanin unit? What is the epidermal melanin unit? So, you all told me it is there in basal layer. But what is epidermal melanin unit? I just need to know the ratio. 1:36, very good. So, EMU, epidermal melanin unit, is 1:36. That means 1 melanocyte transfers its melanin to 36 keratinocytes surrounding it, and that is why we have a uniform skin color. Next question, the other cell is Langerhans cell. You would all tell me that it is in stratum spinosum. What kind of cell is Langerhans cell, and what granules do you see in Langerhans cells? What type of cell is Langerhans cell, and what type of granules do you see in Langerhans cell? It is an antigen presenting cell, very good, and you see Burbeck granules, which are racket shaped granules that you see in Langerhans cells. Coming to the fourth cell, which is the Merkel cell. Where do you see Merkel cell? Absolutely right. So, the keratinocyte followed by Langerhans cells, melanocytes. Now, where do you see Merkel cell? Merkel cell is again seen in stratum basale. So, both my M's, melanocyte and Merkel cell, are seen in stratum basale. Merkel cell are slow adapting touch receptors. They are slow adapting touch receptors. Clear? So, these 4 cells, you should be knowing their location, you should be knowing, and also their origin. Where is melanocyte derived from? Where is melanocyte derived from? Very good, very good. So, melanocyte is derived from neural crest, you are right. Keratinocytes are derived from ectoderm. Should I write it down here? So, keratinocyte is derived from ectoderm. Langerhans cell is derived from mesenchyme. Melanocyte is derived from neural crest. Merkel cell, we are still not clear, but if we have to mark one, we will do ectoderm or neural crest. Okay. So, they are slow adapting touch receptors. So, this is clear. So, this was about the basic. You should know about the structure and cells in the epidermis. Now, what is this layer that I have marked, and what are the pathological features that I see in this layer? I don't think so. The image is quite clear, but if you can make out, yes, this is stratum corneum, very good. And I am seeing parakeratosis. What is parakeratosis? You all know it is retention of nuclei, right? So, why is parakeratosis a histopathological change? Because stratum corneum does not have nuclei usually, but if there is retention of nuclei, that is called as parakeratosis. Lot of times you are asked about the conditions where you see parakeratosis. Yes, so remember it with the mnemonic P is 2, psoriasis, eczema, very important because this is given to you, actinic keratosis. What is with 2S? What is with 2S? Yes, I am so sorry, Dr. Parikshit. I mentioned earlier that the image is not quite clear. It's visible on my smaller screen, but I'm sure it's not visible there. So, I'm sorry for that. Yes, but we are talking about parakeratosis or retention of nuclei here. Usually in the exam, you will be seeing the nuclei. So, psoriasis, eczema, actinic keratosis, seborrheic dermatitis and SCC are 2 more conditions. So, you should be knowing about that, and because sometimes they give you what is the histopathological change which is seen in this. So, parakeratosis is something which is very commonly asked. Okay. Now, this is another important question, image based question. So, what are the lines on my left hand side called? So, they give you these lines and you have to identify these lines. No, lichen planus में parakeratosis नहीं होता. Lichen planus does not show parakeratosis. It shows hyperkeratosis. In fact, this is one difference between LP and psoriasis histopathology. You see parakeratosis in psoriasis, not in lichen planus. Other difference in histopathology, psoriasis, there is absence of granular layer, whereas in lichen planus you see wedge-shaped hypergranulosis. So these are two important histopathological differences that you see in upper layers of epidermis in lichen planus and psoriasis. Clear? Very good. So this is Blaschko's lines, and these are Langer's line. So now a very easy way to see and know that this is Blaschko's lines is whenever you see curves and you see S-shaped lines, these are Blaschko's lines, because these are lines of embryonic development, whereas Langer's lines would be more straight. Right. So sometimes in the question they do not give you the complete image, they give you a part. If the line is curvy, S-shaped, please mark Blaschko's lines, and Langer's lines are more straighter. So these are important differences. Blaschko's lines are lines of embryonic development, whereas Langer's line follow orientation of collagen and muscle bundle. Blaschko's lines has C, so it is constant, and it shows clear midline demarcation, whereas Langer's has anger. Anger is not constant, so it's not constant, and this line is important to give surgical incisions. Is that clear? Now, is the speed fine? Because then I can cover more, but if you feel that the speed is too much, I will slow down. Perfect. Clear? So these are some important differences between Blaschko's and Langer's line, and you should be knowing them. Should we move on to the next image? Now, what is this? I will give you a brief history. A 3-year-old child comes to you with these lesions on the face. You do a gram stain and you get this. So what is this condition and how will you treat it? Okay, so impetigo is right, but it is incomplete. Impetigo are two types, bullous impetigo and the second type. Which type it is? Because in the question, in the options, they may be giving you both the options. So you have to clarify, yes. So this is a non-bullous impetigo, because you're seeing what colored crust are seen in non-bullous impetigo. It is not bullous impetigo, it is non-bullous impetigo, because you see these honey colored crust which are present on the face of a child. This is also called as impetigo contagiosum. So you may be given either impetigo contagiosum or non-bullous impetigo, right? Usually seen in toddlers, usually seen on face as honey colored crust. And if you do a gram stain, you see gram positive cocci, right? Because it's caused by staph and strep. Non-bullous impetigo is more commonly caused by streptococcus. But in developed countries, it can also be caused by staphylococcus. Clear? Very good. Now, what is the complication which can be seen associated with it? Very good. Somebody already mentioned. So, since streptococcus is the more common organism associated with it, post-streptococcal glomerulonephritis is the complication which is commonly associated with it. Right? You should be knowing this. This is an important infection that is asked. Another important question. What is the target in bullous impetigo? In bullous impetigo, I am seeing bulla formation. So, why are the bulla being formed? What is the target structure in the skin which is affected in bullous impetigo? Perfect. So, the next question is this. The target in bullous impetigo is desmoglein. What type of desmoglein? Desmoglein 1. Very good. So, desmoglein 1, which is present in the stratum corneum, is attacked by exfoliating toxin 1 or ET1, which is produced by staphylococcus, and that leads to formation of bulla in bullous impetigo. Clear? So, this image, honey colored crust, you know this. So, now this is something which I have already written. So, this is a complication that somebody was talking about. This is called as staphylococcal scalded skin syndrome. It is a toxin mediated dermatosis caused by staphylococcus. So, staphylococcus causes bullous impetigo, but it can also cause a toxin mediated disorder called staphylococcal scalded skin syndrome. it releases a toxin called as exfoliative toxin 1, which goes into the blood, comes to the skin, binds to desmoglein 1 and causes sloughing of the epidermis. It causes sloughing of the epidermis, and you see, and usually it's seen in infants or neonates. It usually will start with a focus of infection somewhere. So, in the question you would be getting history like a neonate or an infant presented initially with some ear infection or some blisters on the body and then develop this sloughing. So, that was the focus of infection. That is when my Staphylococcus entered into my body, released this toxin, bound to desmoglein 1 and led to this sloughing of the epidermis. Right. So, target here is desmoglein 1, there is Nikolsky if you do is positive, and this is treated with systemic antibiotics. Impetigo contagiosum or bullous impetigo is usually treated with topical antibiotics. The common topical antibiotics that are used are mupirocin, fusidic acid. These are the two common topical antibiotics used. Okay. Thank you so much, Dr. Zishan. I'll pass on your message. So, very good. How to differentiate it from SJS? Because in SJS also you can have Nikolsky positive. So, anybody who can give me answer on how do you differentiate it from SJS? I'll wait for your answers. How to differentiate it from SJS? Body surface area can be involved in both. Yes, somebody was writing it correctly. Please tell me. So, see, body surface area percentage for SJS 10 is less than 10, SJS more than 10. So, body surface area is not important. What is the more important thing? Mucosal involvement is very common in SJS, and in mucosa, at least 2 mucosas should be involved in SJS, whereas here you do not see a lot of mucosal involvement, whereas you can only diagnose SJS if patient has 2 or more mucosal involvement. The second point is clinically, if you look at the patient in SJS, there is keratinocyte necrosis and apoptosis that's happening. So, you actually see some black colored slough on the surface of the skin, which is not seen here. There is more sloughing of the epidermis in SJS. This is more superficial sloughing. So, you do not see that keratinocyte necrosis and apoptosis. Bulla spread sign would not help. So, the most important thing is mucosal involvement and pseudo-Nikolsky sign. But pseudo-Nikolsky sign and Nikolsky sign, when you elicit, it will come out to be positive. So, it is called a pseudo-Nikolsky sign in SJS because there is no antigen antibody deposition. It is because of the sloughing of the epidermis. So, the main point of difference is clinically is mucosal involvement. Plus, in SJS, there will be some history of drug intake. Here, there will be some history of ear infection or something else. Clear? Can we have, ma'am, both image can be seen by? Yes, maybe I'll try that next time. I do not have it currently, but next time when I put this, I'll put that. Okay, coming to the next question. So, a patient presented with pain, tenderness and constitutional symptoms, and when the patient presented to you, I am talking about this image now. So, what is this? So, there was pain, tenderness, constitutional symptoms. Patient presented with an erythematous well demarcated plaque on the hand, and this is the image. So, what is the answer? Yes, so you're right, but the image that I ticked, what's that? That is the difference that I want to know, whether it is erysipelas or cellulitis. Oh, okay. So, okay, listen to my question also. I said pain, tenderness, constitutional symptoms with well demarcated erythematous plaque, and this image specifically has a clearly well demarcated border. In here, I am not able to make out the well demarcated border, but here I can make out well demarcated border. So, yes, this is erysipelas, and this is most likely cellulitis. So, in the question when you are asked, erysipelas is more superficial. It affects the superficial dermal lymphatics, and so my lesion is very well demarcated. Cellulitis on the other hand is deeper. It is affecting the subcutaneous fat. So you do not have a clear demarcation, and here the inflammation is much deeper. Erysipelas is usually caused by group A beta hemolytic streptococcus, whereas cellulitis is caused by staph and strep. Clear? Yes, cellulitis is diffuse, it is deep, right? Whereas erysipelas is more well demarcated. Otherwise, history wise, you will not have any difference in both of them. Clear? Bulla are more common in erysipelas. Bulla can happen in both. So basically, see, bulla formation is happening because the epidermis is also getting affected. Eventually, the inflammation is affecting both. So you can have bulla in both erysipelas and cellulitis. Okay. So that would not be a differentiating feature. The only differentiating feature for you would be well demarcated lesions. Clear? Okay, another very common but very easy question I have already written here. So you maybe a 25-year-old female presents to you with well demarcated erythematous plaque on the underarms which is slightly itchy. One is they can ask you what would be your next test, and the second would be they may give you the test and ask you what it is. Now, why is this question important? Now, if suppose only this image was given, you should be able to differentiate between tinea and erythrasma. So, you all know that yes, I am talking about erythrasma because I have given you this image, right? But what if this image was not given? How do you differentiate between, based on this image and history, between erythrasma and tinea? So, few important differences are erythrasma is not that itchy, plus erythrasma is very well demarcated. Tinea is usually not demarcated. Tinea has scaling on the periphery and tinea is very itchy. But yes, for better differentiation, you do a Woods lamp and you see coral red fluorescence as we see here. Then they ask you what is the organism which causes it. It is Corynebacterium minutissimum. What is the site, most common site of erythrasma? Tell me. No, tinea can have short history. So, long history is not important, but yes, itchiness, not well demarcated and scaling at the periphery are three important things that help you differentiate between tinea and erythrasma. Finally, I got the right answer. So, it is the toe web space which is considered the most common site for erythrasma. Erythrasma can happen on axilla, it can happen on other sites, but the most common site is interweb space. Remember that, okay? So, the most common site is interweb space, and apart from that, yes, it can also affect axilla. And why is it showing coral red fluorescence? Because of production of coproporphyrin 3. That is another important thing that you need to know. How do you treat erythrasma? How do you treat erythrasma? So, erythrasma is treated with topical antibiotics. It is treated with topical antibiotics. Yes. Okay, clear? So, this is another important image. Now, again I have written. So, here is a livestock handler who presents with this image. So, again if something like this is given and livestock handler is given, you should think of, what is this condition? Good. So, you have already given me the answer. Yes, this is anthrax. The bacilli causing is it Bacillus anthracis. It is a zoonotic infection. So, it would be seen in livestock handlers. And this lesion is referred to as malignant pustule, which is a misnomer because it is neither malignant nor do you see a pustule. So, you see a crusted erosion which is present on exposed parts in livestock handlers, right. So, it is a bacterial infection called as anthrax caused by Bacillus anthracis. Yes, you see a black S-char. So, you see a crusted lesion and in the center you see a black S-char. So, you should be able to identify this image as well. Moving on to the next image. So, another important image. So, here I have maybe a 7-year-old child who presents with areas of hair loss with this image. The lesions are itchy and the child is brought by the parents. So, what is your diagnosis here? Again, for the left side of the image. Yes, so the diagnosis would remain Tinea capitis for both these images. But what is the difference between the two images? Both are non-inflammatory Tinea capitis, very good. So, yes, so one is grey patch and the other is black dot. So, Tinea capitis, whenever it's so, when you talk about Tinea capitis, you should know that there are two types, inflammatory and non-inflammatory. In non-inflammatory, I have two types of Tinea capitis, grey patch and black dot. Good. Now, let's talk about grey patch. Grey patch is a type of ectothrix. What do you mean by ectothrix? That the fungus is out invading the hair shaft from the outside. Now, since it's very easy to remember, since the fungus is invading the hair shaft from the outside, you see scales or fungal spores which appear as grey scales on the surface. So, grey patch because you can see grey scales on the surface, and that you can see because it is an ectothrix kind of infection caused by, what is the organism which causes grey patch? Very good, you have already given me the answer. Yes, it's Microsporum canis here, and because there are scales on the surface, it is responsible for outbreaks in school. Whereas black dot is an endothrix kind of an infection. Endothrix would mean that the fungus is invading the hair shaft from the inside. So, my hair shaft gets weak and it breaks off. So, it is the swollen hair shaft which appears as black dot. Now, since the fungus is inside here, you do not see any scales, and that is why when you perform a Woods lamp is also negative here. So, you see a negative Woods lamp in black dot, right? The organism causing black dot? Yes. So, Trichophyton violaceum, Trichophyton tonsurans, these Trichophyton species are the most common species which causes my black dot. Clear? So, black dot you can identify, you can see these black spots, you can see grey in grey patch. This is more angular, this is more circular. And you will not confuse this with alopecia areata. Grey patch cannot be confused with alopecia areata. Alopecia areata is smooth. You do not see any scaling over there. You do not see any itching over there. Clear? Then this is the inflammatory type of Tinea capitis. Whenever in the question they give you anything like there is a boggy swelling, painful swelling on the scalp of a child, only think of carrion. So, boggy, painful swelling on scalp in a child is nothing but carrion, which is the inflammatory type of Tinea capitis, right? What is the organism? Carrion, very good. So, it is caused by जिनके लंबे नाम हैं, they are difficult to remember names. So, verrucosum, mentagrophytes, this is basically, these are what kind of species, okay. So, tell me, inflammatory Tinea capitis are caused by what kind of species? And why do I say that KOH is negative here? Why is KOH negative? Yes, so verrucosum mentagrophytes, very good. So, these are zoophilic species. These are zoophilic species, and because they are zoophilic, my body mounts an intense inflammatory response against it, and that is why you get inflammatory type of Tinea capitis. And that is why when you do a KOH, it is negative because the inflammation kills the fungus. So, it is basically the inflammation causing the disease here, and that leads to carrion. Clear? Then what is this? So, this you all know, since you know all of this. So, this is Favus, another form of inflammatory Tinea capitis. Now, what is Favus caused by? And what are these cup-shaped crusts that you see? So, Favus, you're right, is caused by Trichophyton conleni, and the cup-shaped crusts are called as scutula. Scutula is nothing but these are fungal debris, these are keratinocyte debris which has get accumulated and leads to a cup-shaped crust. This shows a positive wood slam fluorescence. So, grey patch and Favus are two type of Tinea capitis which shows positive wood slam fluorescence. Clear? Okay. Now, look at this image and I will give you a scenario. A 30-year-old patient presents to you with a lesion on the thigh. He says that he has been having this lesion off and on since many months. He applies some OTC creams or over the counter creams. It gets better but recurs. So, what would be your diagnosis? Yes, so the patient has applied some OTC medications and is giving history of recurrent lesions or relapsing remitting lesions which are present on the thigh and are itchy. Okay. So, this is very good. So, most of you are saying it's Tinea incognito. That is correct. This will not be taken as Dhobi H or Tinea cruris or corporis because I am giving you history that the lesion is coming and going again and patient has applied some OTC cream. Also look at the lesion. It does not look like the classical Tinea lesion which is annular, showing central clearing, showing scaling in the border. So, you see a rhythomatous lesions with some papules with hardly any scaling. So, this is a type of tinea called as Tinea incognito or where the tinea is hidden, and this is usually because of some OTC creams application. OTC means over the counter cream applications, and these OTC creams are usually steroids, and because of the steroid the picture of tinea gets modified and that is why it looks different, and here the fungus is hidden and so it is called as Tinea incognito. So, remember, if there is history of relapsing lesion, remitting lesion again and again, patient is giving history of some OTC cream application, please mark your answer as Tinea incognito, not as corporis or Dhobi H. Clear? It can occur at any part of the body. Tinea incognito is not, so most of the teneas that we have studied are located at particular body site, capitis, cruris, manum, pedis, right? But this is a type of tinea which is not limited to any body site, it can happen anywhere. Tinea fasciae can convert into tinea incognito, Tinea cruris can convert into Tinea incognito, corporis can convert into Tinea incognito. But in the exam, if they are asking you about OTC cream and then giving you this image, don't mark corporis or cruris or fasciae, mark it as Tinea incognito. Clear? Okay, good. I don't know why, but this is a image or a question which is almost always asked and I do not really understand why, and so I have to put in here and I am sure you will answer all questions related to it. So, here I have a farmer. So, once instead of rose gardener, they had given you a farmer. So, a farmer or rose gardener both are okay. Presents with some lesions on his legs which are distributed in the linear distribution, and you see this. So, you all know that this is sporotrichosis. Sporotrichosis. And sporotrichosis is caused by Sporotrix kenkai, can be seen in farmer or rose gardener. There is a lymphatic spread to it. What is this that I have made here? Very good, you have given me all the answers. I don't even need to ask. Perfect. So, yes, there are, these are asteroid bodies that you see on histopathology. If you do a PAS stain, you see cigar shaped body. How do you treat? You have not given me that. So, I will revise quickly. Sporotrichosis is a subcutaneous fungal infection. So, fungal infection we divide into superficial, subcutaneous, deep. This is a subcutaneous fungal infection, and in subcutaneous fungal infection we should be knowing about 3 fungal infections: sporotrichosis, mycetoma and chromoblastomycosis. This is sporotrichosis, and how do I identify? I see these linear lesions because sporotrichosis spreads through lymphatic route. So, there is a linear distribution of lesion. It is caused by Sporotrix kenkai, also called as rose gardener's disease. Why? Because it is commonly seen in rose gardeners, because the rose thorns, they get pricked by it, and that leads to implantation of fungus inside the skin. If you do a histopathology, you see asteroid bodies. If you do PAR stain, you see cigar shaped bodies. How do you treat? Itraconazole. Okay. So, yes, you are right, you can give patient itraconazole. If itraconazole is not there in the option, you can say potassium iodide. Even if that is not there in the option, then you mark terbinafine. But I do not think terbinafine should be marked. But there was once a question where neither itraconazole nor neither potassium iodide was given. So, then you can mark that. But yes, the best choice would be itraconazole and potassium iodide. Clear? Okay, great. So, this is what you should be knowing. Sporotrichosis is caused by Sporotrix kenkai, which someone rightly mentioned is a dimorphic fungus. So, sometimes they also give you the image of Sporotrix kenkai. I'll put that image next time, but you can look on the Google. There is an image of Sporotrix kenkai. It is a dimorphic fungus. Clear? The other subcutaneous fungal infection that you should be knowing is this. This is called as mycetoma or Madura foot. So, whereas sporotrichosis is present in a linear distribution, here you see the swelling which is there usually on the feet with this discharging sinuses. So, the classical feature is swelling of the foot, which is painless. So, it is painless swelling where you see induration or tumefaction, and you see these discharging sinuses. And if you feel this discharge, this is a very, very grainy discharge, because here they are discharging grains which are nothing but colonies of fungus which are there, right. So, your mycetoma is of 2 types: actinomycetoma when it is caused actually by bacteria, and eumycetoma when it is caused by fungus. Now, the difference between actino and eumycetoma would be actinomycetoma is a bacterial infection. So, it is more sudden in onset, whereas eumycetoma being fungal takes a long course of time. Right. Then the color of the granules is important. In eumycetoma, you see usually black or brown granules, whereas in actinomycetoma, you see yellow and red granules. You treat actinomycetoma with antibiotics, eumycetoma you treat with antifungals. And also in eumycetoma, usually you need surgical intervention. Clear? Yes, actinomycetoma, you see yellow or red granules. Okay, great. So, I see that all of you are very well prepared, and I am so glad that you all know so much of dermatology. Great. So, let us move ahead. Are you guys okay? If anybody is finding any issues following it, then you can tell me. We can go slow. The idea is to quickly revise you the maximum amount of dermatology that I can in this 1 hour. Okay, so moving on till I get your responses. This is a child who's 7 years maybe, presenting with this asymptomatic lesions on the face, can be present on any part of the body. You look at this and you diagnose it as Molluscum contagiosum. Perfect. So, I hope you all become dermatologists in future. You know so much. You are able to identify all the disorders based on images. I am sure you will do very good when you are into clinical practice. So, yes, so these are umbilicated papules, and this umbilication is the giveaway point in Molluscum contagiosum. So, a lot of times you will see many such papules on the face, but this umbilication gives you the hint that yes, this we are talking about Molluscum contagiosum. And we do hardly histopathology, but in case you do histopathology, you see these eosinophilic inclusion bodies, which are called as Henderson-Peterson bodies. Henderson-Peterson bodies. Good. Right. So, why are you confused, Dr. Parikshit? Is it the lectures or are you talking about something else? So, otherwise everything looks fine, but you can share what are you confused about. So, this is how it presents. Unligated papules which are asymptomatic can be present on face or any parts of the body. If it is present in the genital area only, think of STI. Histopathology, you see Henderson-Peterson body. How do you treat? You have to do TCA prick, you have to do cautery, you have to do needle extirpation. There is no oral medication that you have. Next important question in this subtopic is HPV virus, which again the examiners are fond of, and you should be knowing the types of HPV virus. So, I am sure you all know the mnemonic here also, DSP, come eat a burger. So, deep planter, superficial planter. So, you have to remember that if it is a deep planter wart, it is caused by HPV1. The most commonly which is asked is plain wart. You get an image of plain wart and you are asked what are the HPV types associated with it. It is 3 and 10. You should also be knowing about common wart 4, 2 and 27 and anogenital. Anogenital, know that there is a low risk HPV and high risk HPV. Low risk is 6 and 11 and high risk is 16, 18. These are the most important. So, Dr. Debiki, the histopath differentiated with keratoderma acanthoма. So, I think you are talking about differentiating it with keratoacanthoma, right, which is a type of well differentiated SCC. So, when you see a keratoacanthoma, you do not, I will come back to this image. So, here you see this kind of a thing, hai na, eosinophilic, and you see a lot of eosinophilic inclusion bodies. In keratoacanthoma, you would see just an epidermal lipping, and there will be lot of necrotic or dead skin which will be there. So, here you see these invaginations and you see eosinophilic inclusion bodies. In keratoacanthoma, which is a well differentiated SCC, you see a little epidermal lipping, and in the center there is basically a crust which is formed of dead keratinocytes. So, you can differentiate it based on the image. Okay. Good. Yes. So, you are right, Dr. Parikshit, K as lipping. So, we are done with that. Okay. So, HPV, we come back to HPV. So, we have to remember these 3 main types because this is the most commonly what is asked. So, what is this? Okay. Now, tell me what is this image on the right hand side. So, this one, I will give you a history. There will usually be a history of immunocompromised state. So, there can be organ transplant history, history of HIV or something, and on the face of the patient, you have these numerous lesions, right? Yes. So, this is verruca plana, and what is verruca plana caused by? DSP, P was plain wart, right? So, plain wart is 3 and 10. Right. So, this is how you need to remember. So, they will give you the image and they will ask you the HPV subtype. So, verruca plana is usually seen on face, it is seen in immunocompromised state, and you see HPV 3 and 10. Whereas, this is the common type of wart which is verruca vulgaris, which has a rough hyperkeratotic verrucous surface. Clear? Okay, what is this? Why do I always give you hints here? Now, what is this condition called as? I have given you the hint that you see target lesions, you see a center, then another zone, then another zone. So, these are target lesions which are seen in Erythema multiforme. Now, Erythema multiforme is a reaction pattern where you see target lesions, and these target lesions can happen either with viral infection or they can also happen with drugs, but the most common cause is HSV. So, how do you get a question? You can get a question like a patient who presented with recurrent genital ulcers or recurrent erosions around the lips or recurrent vesicles around the lips is now presenting with these lesions. So, they are giving you a hint that patient has HSV in the past and now is developing target lesions. So, you know this is Erythema multiforme, but you should also know that EM can also be caused by drugs. Clear? Yeah, it can also be seen with Lyme's disease, but HSV, mycoplasma and drugs are the most important ones. Okay. So, this image is again important. You see an image like this, you know that this is a target lesion because you are seeing 3 zones, and then you can diagnose it as erythema multiforme. Okay. Okay. Erythema multiforme versus Lyme disease. Yes, yes. So, see EM, okay, come back to this. So, EM has 3 zones and it is stable. It's not increasing. Whereas in Lyme's disease, it's a centrifugally spreading rash, right? So, you will have a central punctum or a bite mark and then a wavy lesion which would keep spreading centrifugally. So, you do not see 3 zones. You do not see 3 zones in Lyme's disease. Clear? In target lesion, you see 3 zones, and the center zone is not just a bite mark. It's a necrotic lesion or a bulla, or you see a little black thing. And here you would be typically given a history that the rash is spreading. Okay, so it's a centrifugally spreading annular erythematous rash in Lyme's disease. In target lesion, you have 3 zones. Clear? Did we come to shingles? Oh, very good. So, you saw my next slide and you are already there. Another very common image given to you. Yes, you are all right. It is shingles or herpes zoster. Now, the question to you is that suppose a patient comes to you with this lesion. What would you counsel on why did the patient get this thing? You are right, this is herpes zoster, so it's caused by varicella zoster virus. So, is it actually an infection or something else which leads to this? So, this is very important. This is asked a lot of times. Whenever it's easy to diagnose, right? Whenever you see a dermatomal lesions, you see painful lesions, you see vesicles, you know you have to mark it as herpes zoster. It is caused by varicella zoster virus, the same virus which is causing chicken pox. So, when it caused chicken pox, this virus got latent in my body, and it is the reactivation of this virus which leads to herpes zoster. So, reactivation along a particular dermatome leads to herpes zoster. So, it is not an actual infection, it is reactivation of virus which has been lying latent in my dorsal root ganglion. So, this virus is latent in dorsal root ganglion. Clear? What is Hutchinson's sign related to this? Very good. Yes, so Dr. Debaki, you are right. Usually it's seen in immunocompromised state, but nowadays we see in a lot of healthy adults also. Now, I was talking about a Hutchinson sign. Can anybody tell me? Yes. So, Hutchinson sign is because of involvement of nasociliary nerve. So, if you see vesicles on the tip of the nose, then what will happen? There are high chances that the patient will have ocular involvement, because nasociliary nerve is a branch of trigeminal nerve. So, it can affect the ophthalmic division of trigeminal nerve and lead to herpes zoster ophthalmicus. What is the dose of antiviral that you give in herpes zoster? Another important question. How do you treat herpes zoster? Yes, 800 milligram of what, and how, what is the frequency? No, not BD. You are all right. 800 milligram is fine, but what do you give it? BD, you give it TDS, how do you give it? Yes, thank you, Dr. Parikshit. It's acyclovir 800 milligram 5 times a day. So, you need very high dose of antivirals, and since the compliance is little difficult with this, these days we are using valacyclovir, which is given as 1 gram 3 times a day. Okay, so acyclovir 800 milligram 3 times a day, or 5 times a day, or you can give valacyclovir 1 gram 3 times a day, right. So, this is very important. Okay, moving on to this, I have given you again. So, you see these verrucous whitish projections on the lateral aspect of the tongue. So you are usually asked the diagnosis, you are given this image and you are asked what it is. It is oral hairy leukoplakia. It is caused by Epstein-Barr virus and it is commonly seen in HIV positive individuals. So this image usually they don't ask you anything else, you have to just identify. So look at these white corrugations present on lateral aspect of the tongue. This is oral hairy leukoplakia caused by Epstein-Barr virus. Okay, no, it's not pre-malignant, you're right. Sorry, I mean it is not a malignancy. What is this? Another image which is very commonly given. Yes, it is caused by HHV8. It is again seen in HIV individuals. So this is Kaposi sarcoma. So when you see this, so usually in the history you would be given that HIV positive individual presenting with these dusky red or bluish papules and nodules. What is it? So whenever anything is dusky red or bluish, that means it has a vascular origin. So these are vascular tumor of endothelial cells seen in HIV positive patients. This is caused by HHV8 and it is called as Kaposi sarcoma, right? So this image is also very commonly given. Okay, so erythroplakia and its tumor. So I would want to discuss erythroplakia separately because it's really not important for your exam. In erythroplakia, you get red patches. That's something different, not pertaining to the exam, not us. So I think we'll discuss that later. Okay. Moving on to the next topic, I have a 20-year-old male or I can have a 10-year-old male who presents with this asymptomatic lesion on the buttocks, present since a long time. What do you see? Yes, this is lupus vulgaris and it is a type of cutaneous tuberculosis. And why do you say lupus vulgaris? You have to see for 2-3 points. One, look at this. So it's a peripherally spreading lesion which is showing areas of central atrophy. So it spreads at one end and gets atrophic at the other end. This is one important thing that you see. And second thing that you've already mentioned, when you do a dioscopy, you see apple jelly nodules because these are granulomatous lesions. So these are granulomatous lesions. So the most common form of cutaneous TB is lupus vulgaris in adults. So that is another question that has been asked. Most common form of cutaneous TB in adults is lupus vulgaris and you see apple jelly nodules and you see this central atrophy, right? And what is this then? This is the most common form of cutaneous TB that you see in children. So usually there is an internal focus, there is a lymph node which is involved and then it breaks down into the skin leading to these small ulcers or discharging sinuses. I'm so sorry, just give me a second. Sorry, my YouTube took me somewhere else. So yes, you're all right. So this is scrophulloderma. What is the type of what is the type of inoculation or spread that you see in scrophulloderma? How does scrophulloderma happen? So there can be hematogenous, lymphatic, autoinoculation. So what is this type of spread in scrophulloderma? How does the TB bacilli come to skin basically? So it is a contiguous spread. There is an underlying bone, lymph node, gland which is affected and from that there is a contiguous spread of the bacilli into the skin, breaks down into the skin and leads to scrophulloderma. This is the most common form of TB that you see in children and the most common site is cervical lymph node TB which is affected and so on the neck you get scrophulloderma. Clear? Then you should also be knowing about tuberculosis. So in tuberculosis, they ask you about the criteria and you have to identify. So you know that tuberculosis are type 4 hypersensitivity reaction. Okay, so these are reactive tuberculosis. It's not actual TB bacilli affecting you, but it is the bacillary toxins or bacillary remnants which generate a type 4 hypersensitivity reaction which leads to cutaneous manifestations. So you should be knowing about the criteria here. So there has to be a primary focus which is there, a positive Monto's test, tuberculoid histology, response to ATT and So there is a primary focus elsewhere. From there, the toxin or the dead bacilli generates a hypersensitivity reaction. So patient has good immunity. So my MON2s would be positive. And then it leads to hypersensitivity reaction somewhere else, which if you biopsy, you see a positive tuberculoid histology. And if you give ATT to the patient, patient improves. Right here, if you do AFB or anything, that would be negative because it's a hypersensitivity reaction, not a direct infection. There are 2-3 kinds of tuberculoids, mostly you should be knowing about 2, lichen scrofulosaurum and papillonecrotic tuberculid. Yes, if you do a culture, it will also be negative because there is no active TB bacilli which are present there. So, lichen scrofulosaurum is something that you see on the trunk, usually seen in children. You have this micropapillar lesions, and when you biopsy, you see superficial granulomas. Whereas papillonecrotic tuberculosis is the reverse. It is seen in adults, it is present on hands and feet, exposed parts basically. So, arms and legs, you see necrotic papules which are there, right. So, you should be able to identify the 2 kinds of tuberculosis. Coming to the next important section, which is leprosy. So, I am going a little quick because I want to show you more images before we finish. So, I will now mostly talk about the important features which you see on the images and help you identify. So, whenever you are given a patient of leprosy, they can ask you about the spectrum or reactions. So, I will quickly show you images of all the spectrum. So, indeterminate leprosy is something which is endemic to India. It is not included in Ridley-Joplin classification. So, here the patient will present with usually a single lesion which is not very well demarcated, but in these lesions there will be no loss of sensation. If you do a biopsy, you do not see any AFP, there is not much infiltrate, there is just a very mild perineural or periappendageal infiltrate. So, this is the most common form of TB that you see in India. Right, but the more commonly this is the spectrum which is asked to you, which is borderline tuberculoid. Here you have to identify 2 main features. One, the presence of pseudopodia and then satellite lesions. So, here the number of lesions. So, usually you are given number of lesions, you are given measurements. So, BT Hansen usually there are 10 to 20 lesions on 10 to 20 centimeter in size, but the classical thing is you see these satellite lesions because the infection is spreading here. If you check for anesthesia, there is hypoesthesia or there is loss of sensation, but it is not 100%. Okay, clear? Good. BL on the other hand presents with numerous lesions which is tending to be symmetrical but not completely symmetrical. So, you have numerous small lesions, and if you look at the lesions, they show inverted saucer appearance, and if you examine the patient, you have glove and stocking anesthesia. BL Hansen is when the bacillary load is very high and immune response is not able to capture it. So, you see numerous lesions, you see inverted saucer appearance, you see glove and stocking anesthesia. Clear? Then this is BB Hansen. BB Hansen is the most unstable form of Hansen. Here you see geographical or map like configurations. So, I am giving you the important points: satellite lesions, pseudopodia, BD Hansen; inverted saucer appearance, BL Hansen; BB Hansen, geographical or map like configurations. Right, this is the unstable form. My leprosy is shifting from tuberculoid to lepromatous pole here. Punched out, yes, you are right, is more common in BB than BL. Can be seen in both the lesions, but it is more common for BB. But inverted saucer is for BL, right. So, BB will have map-like or geographical configurations. Another important image that is given to you in leprosy is these kinds of images, and you have to identify what kind of reaction the patient is undergoing and how do you treat. Treatment is the most commonly asked, so please remember whether type 1 or type 2 lepra reaction, both the treatment of choice is steroid. So there is no confusion there. So sometimes if you are not able to identify based on the image or question whether it is type 1 or type 2 and the examiner is asking you about the treatment, please mark steroid. Steroid are the drug of choice for both type of reaction. Clear? Now coming to these two types of reactions that you see in leprosy. So this is type 1 lepra reaction, where what is happening? Type 1 lepra reaction is when you have initiated MDT for the patient. So you have given patient anti-leprosy treatment. Now that treatment is killing the bacilli. That leads to a hypersensitivity reaction. So it is a type 1 lepra reaction where actually type 4 hypersensitivity reaction occurs. Here the existing lesions become more prominent. So it is seen in upper spectrum. It is a type of type 4 hypersensitivity reaction. It will usually happen after starting treatment. Existing lesions become more prominent, swollen and red, and you see nerve involvement, which can be new or there can be nerve abscess formation, right? So these are all important pointers towards type 1 reaction. Moving on to the type 2 reaction, which is also called as ENL or erythema nodosum leprosum. This will be seen in lower spectrums of leprosy. Here the patient is not able to mount a very good immune response. So what is good immune response in leprosy? It is the cell mediated immunity. So here I see cell mediated immunity in type 1 reaction, but in type 2 reaction it is seen in lower spectrum. So here I see type 3 hypersensitivity reaction, which is formation of antigen antibody complexes. Antibodies are not protective in leprosy. So in lepromatous pool you see more of antibody formation. Clear? Okay, no questions. So type 3 hypersensitivity reaction. Now here the triggers are some kind of stress, pregnancy, infection, stress per se. So that leads to development of new crops of lesion. Here my existing lesions were getting affected. In ENL, it is the new crops of lesions that happen with evening rise of temperature, usually seen on lower legs or on the body. But here new crops of lesions come every day with evening rise of temperature, subside with pigmentation, then again a new crop of lesion appears. So the description of both the pathophysiology of both the reactions are different. The good part is treatment is oral steroids. Clear? So you should be clear about type 1 and type 2 lepra reaction. Then you should be knowing about the treatment of leprosy. They usually give you these blister packs which you should be able to identify. So the pink one is the blister pack which we use in adults and the yellow is for the blister packs that we use in kids. I would want that you should read the dosing by your own. We should not waste time discussing the dosing here, right? So but you should be able to identify these blister packs. Clear? So these are the common images which are given to you in leprosy. I'll move on to the genital ulcer disease now. You can see yellow or brown, okay? Yeah. Okay, so next important question which is asked to you is on genital ulcer disease. They give you a genital ulcer, you have to identify and you have to differentiate them into these 5 categories, which I think you would be very clear about because we've discussed this n number of times. But this is a table which would help you. You have it in your notes. I'll straight away move on to the images. So these are the common images that are given to you for this kind of disease. So you all know what am I talking about here? Very good. So yes, I'm talking about syphilis here. So my first kind of genital ulcer is syphilis. What do you see? In the primary stage, you see a chancre, which is painless, single and indurated. 3 main important things. You see a single painless indurated ulcer. In secondary stage, you see secondary syphilis. So this is the most common image which is given to you. A truck driver or someone who has a positive history of contact presents to you with hyperpigmented lesions on hands. So this is secondary syphilis where my bacilli has transmitted to the bloodstream. Then what do? You do these tests, which is dark ground microscopy, because this bacilli is not stained with regular staining. So, you do dark ground microscopy and you see these fluorescent wavy organisms, which is called as Treponema pallidum, right. So, these are the common images. Chancre, see, well defined, painless, indurated. Then on the hands, and then you are given this dark ground microscopy. So, this is all pertaining to syphilis. This is chancre. How do you treat? You give benzathine penicillin. So, this is an ulcer which will be very, very easy to identify if given to you in the exam. Okay, we will move on. Then what is this ulcer? You see numerous vesicles, coalescing erosions which are present in the genital area. Very important, you may get a history of recurrence here. So, the second type of genital ulcer is herpes genitalis. So, important things here, short incubation period, very short incubation period, history of recurrence. Here you do not see actual ulcer, you see erosions and vesicles which are coalescing and are very painful. So, painful erosions, coalescing erosions, short incubation period. What do? You do a Zang smear and you see these multinucleate giant cells or MNGs. Right. So, sometimes they ask you to diagnose, sometimes they ask you what test would you do, or sometimes they ask you treatment. That is the three most important thing that you want to ask you in genital ulcer disease. So, you all know that acyclovir is the treatment of choice. So, this is a very, very important image that is given to you. This tells you that there are multinucleate giant cells and this is a patient of herpes. So, multinucleate giant cells, coalescing vesicles and erosions, history of recurrence, short incubation period. Clear? What's this? Again, just like herpes, I have multiple lesions, I have painful lesions, short incubation period. So, everything similar to herpes, but what is the difference? Here I do not see coalescing vesicles and erosions, I see ulcers which have a soft base. So, this is my chancroid and the ulcer is also called as soft chancre. It is caused by Haemophilus ducreyi. It is caused by Haemophilus ducreyi, and here also just like syphilis, everything is same, multiple, painful, short incubation period, but here you get actual ulcers which have a soft base, right. And yes, you are all right. What do? You do a gram stain and you see this school of fish appearance or railroad track appearance, which are nothing but gram negative rods which are arranged in chain, right, which are arranged in chain. How do you treat? You give ceftriaxone or cefixime. Okay, so you should be able to identify chancroid. Then next, what is this? Yes, please read the kits also. I do not think I have an image of the kits and I do not have time to discuss the kits because there are more images to show to you. Okay, yes, so it is not LGV. You see, you have a beefy granulomatous bleeding ulcer. So, whenever you see beefy granulomatous ulcer which bleeds easily on touch, this is called as Donovanosis. And is caused by Klebsiella granulomatis or Campylobacter granulomatis as it was earlier called. And what is this? There are no lymph node that you see here. So, what do you see? You see pseudobubo. You see pseudobubos here, okay. And here if you do a Giemsa staining, you see safety pin appearance. So, these are all the important points about Donovanosis. Caused by Klebsiella granulomatis, causes beefy granulomatous red ulcer which bleeds easily on touch. You see a pseudobubo sign and you see safety pin appearance on Giemsa staining. Clear? Clear everyone? Then this is my last ulcer, which is LGB, which does not present with ulcer. It presents mainly with painful buboes. It presents mainly with painful buboes because ulcer happens in the primary stage, but it is a very transient ulcer. So, here there is lymphatic spread of the infection, and it is usually in the secondary stage that patient presents to you with multiple suppurative multilocular lymph nodes which are there, which are painful, patient limps on walk, and there is something called as groove sign of green blood. So, this is seen in lymphogranuloma venereum. LGB, right. So, groove sign is because of involvement of femoral and inguinal loads, the Pauwels ligament, it becomes taut, giving rise to groove sign of green blood. Clear? So, these are my 5 genital ulcers which you should be able to identify. Yes, there can be saxophone appearance of the penis in the 3rd stage. Because of lymphatic obstruction, there is a deformity which is left, which is called as saxophone penis in males, and in females it is called as estheomy. Estheomy. Yup, good. Urethral discharges may be given to you. Image helps sometimes because if you see thick, purulent, profuse discharge, you have to think of gonococcal urethritis, right. So, gonococcal urethritis would be thick, purulent and profuse, whereas if you see a watery, thin discharge, light discharge, then you have to think of non-gonococcal urethritis, and common organisms causing NGU are chlamydia, mycoplasma, trichomoniasis and HSV. So, now why is this important? Because once there was a image and you have to identify the organism, and even chlamydia was not given. So, you should know that NGU is not just caused by chlamydia, but also by mycoplasma, trichomoniasis, HSV and other organisms. Yes, even ureaplasma. Okay. So, you should be able to identify here. If you do a gram stain, you would see these gram negative intracellular diplococci, which is nothing but Neisseria gonorrhea, whereas in non-gonococcal urethritis, you would just see PMNs, you would not see any organism there, right. How do you treat? That is treated only with azithromycin, whereas gonococcal urethritis, along with azithromycin, you give cephalosporin. Clear? So, this image also you should be knowing. Another very commonly asked image is they give you this and they ask you what it is. So, just give me a name for it. It is a type of anogenital wart, also called as condyloma acuminata, but this is what image is, something they are very fond of giving you, and they ask you what it is. It is a type of anogenital wart, but what's the exact name for it? What's the exact name for this image? So, it's called as Buschke-Lowenstein tumor. Buschke-Lowenstein tumor is a type of anogenital wart which happens with high risk HPV, where you see a cauliflower like mask hanging from the genital region. So, they give you this image and they ask you what it is. It is Buschke-Lowenstein tumor, right. Okay. Next important topic, again something you would be very much aware about. They can give you images like this. A 30-year-old or a 40-year-old female presents with oral erosions with flaccid bulla. Oral erosions with flaccid bulla. So, I am just giving you very important pointers. So, please remember these, please revise this, because this will help you clinch most of your questions. So, you are right, pemphigus vulgaris. So, 2 things if you get flaccid bulla, oral erosions, pemphigus vulgaris. In addition, you may be given that Nikolsky sign is positive, right. So, that may be given, and they may be giving you a DIF image, which I will just show you. On the other hand, if you have been given an image like this, where you see mainly crusted erosions on seborrheic distribution with no mucosal involvement. So, you do not see mucosal involvement and you see something like this, then you have to think of pemphigus foliaceus. Pemphigus foliaceus happens because of desmoglein 1. F for first, desmoglein 1. PV was desmoglein 3. Okay. PV is vulgaris. Vulgaris means more common. So, flaccid bullae, oral erosions, PV. No erosions, mostly crusted erosions in seborrheic distribution with no mucosal involvement is pemphigus foliaceus, and you should know the target antigen. What is this? Here I tell you that the bulla are tens. So, if I see tens bulla, if I see them preceded by itching, urticaria, so if the lesions are preceded by itchy lesions, urticarial lesions, and then patient develops tens bulla, you are usually given an elderly. Nikolsky is negative. Then you have to think of bullous pemphigoid, and your target antigen here is BP antigen 1 and 2, right? So, you should be knowing the antigens, you should know Nikolsky, and you should be able to see if there is tens bulla. We know that it is a subepidermal bulla that we are talking about, right? So, quickly, pemphigus and pemphigoid, you already, some of you told me, is differentiated on the basis of MINAR. Mucosal involvement, intraepidermal bullae, positive Nikolsky sign, presence of acanthocytes or Zang cell is only seen in pemphigus, not in pemphigoid, because it is a subepidermal split. There are no keratinocytes there. So, you do not see Zang cells in pemphigoid group of disorder, you see it in pemphigus group of disorder. Row of tombstone on biopsy is another important sign that you see with pemphigus group of disorder, row of tombstone appearance. So, all these are important signs and features that you see in pemphigus versus pemphigoid. How do you differentiate foliaceous and vulgaris? It's easy. Foliaceous, you see no mucosal involvement. Vulgaris, you see mucosal involvement with flaccid bullae. Clear? So, this we know. Then they can be giving you this. What are these? These are Zang cells, also called as acantholytic cells, which is seen in pemphigus group of disorders. And this is my row of tombstone appearance that I just told to you about. So, this is row of tomb. Because my keratinocytes are separated from each other in the basal layer, it looks like there is a tombstone running, right? So, these are both features of intraepidermal bullous disorders. Now, what do you see in DIF? Another common image that is given to you. So, this is a DIF image of intraepidermal disorder, and this is a DIF image of subepidermal disorder. So, this is what you see in BP, and this is what you see in pemphigus vulgaris. So, you see a fishnet pattern in pemphigus vulgaris, whereas in BP, since it is a subepidermal split, you see a linear fluorescence, right? DIF is the gold standard test, remember, it is the gold standard test. Clear? So, this is a DIF image and you should be knowing about this. I'll move to this one. Here I have a patient who presents to you with itchy, recurrent itchy lesions on the extensors. You do a DIF and you see this. So, what is this? Quickly. Very easy. Yes, this is dermatitis herpetiformis. It is a type of subepidermal disorder, but here you do not see any bulla. You just see itchy excoriated lesion. The target antigen. What is the target antigen here? So, yes, here you are seeing papillary tip immunofluorescence, but what is the target antigen? Yes, it is tissue transglutaminase. Tissue transglutaminase is the antigen here, and I am not discussing the treatment. You all know that you have to avoid gluten and give dapsone here. Avoid gluten and give dapsone here. And when you avoid gluten, you avoid barley, rice, oats, wheats, and you can give maize and rice. Clear? Easy. Okay. Okay, another very common image which is given, very easy. You all know this is alopecia areata. You see, how do you differentiate it from tinea? Smooth patches, no scaling, white hair being preserved, and if you look at the periphery on dermoscopy, you see exclamation mark here, exclamation mark here. Okay. So, yes, you are right, this is alopecia areata. It is an autoimmune condition, T cell mediated disorder, where you see these smooth bald patches which are asymptomatic, non-scaly, non-itchy, preservation of white hair, and on the periphery you see exclamation mark here. What is this? A patient comes to you, he is socially withdrawn, you see on one side of the head, and you see broken hairs of various length. So, 2-3 things, you will be given a history of psychiatric issue, you will be given hair of unequal length, and then you know that yes, you are dealing with trichotillomania, trichotillomania, right. So, here there is Friar-Tuck sign is positive, trichobezoar may be there, and how do you treat these patients? You have to give antipsychiatric medications, psychiatric medications. So, you can use N-acetylcysteine, you can give cognitive behavioral therapy. So, treatment is based on that. We'll skip this. I will go to the more important images. Koebner's phenomena is something that you should be able to identify. Koebner's phenomena is when you give a trauma to the lesion, lesions of similar morphology develop along the lines of trauma. True Koebner's is seen with psoriasis, lichen planus and vitiligo. False Koebner's is seen with verruca or warts and molluscum. So, just you need to know this. So, psoriasis, LP and vitiligo you see true Koebner's, and verruca and molluscum you see false Koebner's. Histopath of psoriasis we have partly discussed. So, what is this? I have maybe a 12-year-old child who is presented with these crops of erythematous small scaly lesions on the trunk. The patient gives history of recurrent sore throat. So, yes, so this is another question which is asked. So, guttate psoriasis, you have raindrop pattern of lesions. So, you have raindrop pattern of lesions, you have small erythematous scaly lesions. There is history of streptococcal infection which is given to you. Streptococcal infection. Here the treatment is antibiotics. So, this is a different form of psoriasis where you are not giving methotrexate, you are not giving other medications for psoriasis, you are treating with antibiotics. Yes. Okay. Just to identify, you can be given this image. This is congenital melanocytic nevi, usually present at birth, single lesion, very, very hyperkeratotic, full of rugosities. So, this is congenital melanocytic nevi. I was once asked, so I decided to put on this image here. Again, you should be able to identify nevus of Ota and Ito. It's Ota which is usually asked. It is a dermal melanocytic nevi seen on trigeminal division. You see these bluish to brownish specks of pigmentation with a bluish background and very commonly sclera is affected, and it is unilateral, right. So, nevus of Ota is something you should be able to identify. What is this? A patient was wearing some rubber chappals, developed this. This patient was putting bindi and developed this. This is not vitiligo, it is chemical leukoderma. It is chemical leukoderma which happens because of contact with certain chemical agents which leads to depigmentation. So, in this case it is rubber which contains monobenzyl ether of hydroquinone, and here it is bindi which contains para-tertiary butyl phenol. So, either they can ask you the diagnosis or the agent. Clear? Okay, we will move on. Again, I will not be discussing the details, but lot of times you get this image of this test and they ask you what test it is. So, it is the patch test. It is a type 4 hypersensitivity reaction used to identify contact allergic dermatitis. We usually put it on back and you read it after 48 hours, but the best reading is done at 96 hours to look for delayed reactors. Right. So, 48 hours you read it, but if you have to choose one answer, you say 96 hours. Right. Good. What is this image showing? You see an extra fold of skin below the eyes. What is this, and it is seen in which condition? So, this is Denny-Morgan fold. You're right, you also see some madarosis here, but what am I mainly seeing is this extra fold of skin on lower eyelid, which is called as Denny-Morgan fold, seen with atopic dermatitis. Another image based questions that comes in the exam. Again, you should be able to identify these things. If you get something like this, you see reddish papules present on the nasolabial fold, present in a child who has other features. Think of adenoma sebaceum. Adenoma sebaceum is a feature of tuberous sclerosis. So, in genodermatosis, you should be able to identify these things, like this is Keenan's tumor, this is collagenoma, these are ash leaf spots, and this is adenoma sebaceum, which is seen with tuberous sclerosis, right. Then they give you this image where you see lot of periorificial lentiginosis. If you see periorificial lentiginosis, P for periorificial, P for Peutz-Jeghers. So, Peutz-Jeghers is an autosomal dominant condition where you see periorificial lentiginosis, and it is associated with a family history of some gastric malignancy or carcinoma. So, a patient showing this manifestation should be getting a regular endoscopic examination done. Yes, you are right, STK11 is the gene involved. Very good. Okay, I will go on to the, okay, then another image which is given to you, a child presenting with rough hyperkeratotic papules on the elbows and knees which are asymptomatic. This is phrenoderma, happens due to deficiency of vitamin A and also lot of essential fatty acids. Okay, so you should be able to identify phrenoderma, which looks like toad skin. Another common, very common question or image which is given to you, you have eczematous lesions on photoexposed parts, you have Castle's neck appearance. This is seen with pellagra, which happens because of deficiency of niacin or nicotinamide or niacinamide, right? And it is associated with 4Ds, dermatitis, diarrhea, dementia, and eventually death if not treated. Clear? This you know. Another very common image, a 70-year-old male presents to you with this lesion. What is this? Somehow very fond of this image. You are right, this is BCC or basal cell carcinoma. You see an eroded ulcer with overhanging margins with telangiectasias on the periphery. This is BCC, and that is what they tell you. They give you an image and you have to identify it. This is basal cell carcinoma. So, I have only skipped the things which I know you know. So, I am making sure that whatever is the most important topics that I am covering. Like I have skipped scabies, which you all know, right? So, do not worry. Per se also you understand that 1 hour is too little time to teach you whole of dermatology. So, I am trying to cover the most important topics. What is this? Another common image given to you. An adolescent male presenting with this hyperpigmented lesion on the back. What do you see? You see a lot of hypertrichosis over it. So, what is this? Yes, so another important image based question. So, this is Becker's nevus. Becker's nevus is seen in adolescent age, hypertrichotic, hyperpigmented lesion. And I think, yes, this is the last image. What is this? So, you can be given this image or they can be asked about it. So, what is this? This is dermographism. It is a type of physical urticaria where when you stroke the skin, you develop linear wheals along the stroking of lesions. So, this is dermographism. It is a type of physical urticaria. It is not urticaria pigmentosa. This is urticaria pigmentosa. Urticaria pigmentosa is not a type of urticaria. It is a type of mastocytosis which you see in less than 2 years old children. So, they present with urticarial wheals which are settling down with hyperpigmentation, and you stroke the lesions and you see a positive redness, swelling which happens, which is called as Darier's sign. So, this is urticaria pigmentosa. It is not the same as dermographism. Urticaria pigmentosa is a type of cutaneous mastocytosis seen in less than 2 years old children. Okay, so that finishes most of the dermatology. You want to discuss scabies? Okay, I'll do that before I leave. So, scabies, it's I think very what you get in scabies is you should be given a history of family history of lesions, nocturnal itching, patient develops itchy excoriated papules, you examine closely and you see burrows. So, burrows are tract which are laid down by the female mite into the stratum corneum, but they can go up to stratum malfigi. Remember that. Then this is the circle of Hebra. Circle of Hebra is basically Hebra described how the scabies lesions are distributed. They form an imaginary circle on skin, and that is why it's called as circle of Hebra. So, can happen in genital area, interweb space, axilla, umbilicus, all this region. Scabies is caused by a mite called as Sarcoptes scabi. Treatment of choice is 5% permethrin. 5% permethrin is the treatment of choice for all age groups, pregnant patients, children. However, if you have a less than 2-month-old infant and there is option of precipitated sulfur, you can mark that. GBHC was used for scabies but not used anymore because of neurotoxicity, and so most commonly used treatment agent is 5% permethrin. Ivermectin is the oral drug which is used for scabies again, but it is not the treatment of choice. Clear? So, I think I'll wind up my session here. Believe me guys, you guys are amazing, you know a lot. Just keep up this tempo of yours and you'll come out with flying colors, and I'm sure you'll do very well in your exam, and I wish you very best for the future. Thank you so much.